Ma'am, we are starting now, ma'am. Madam, we are starting now, ma'am.
I am audible?
Yeah, ma'am. Yeah, ma'am. So, good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So, the topic for today's webinar is poor ovarian reserve. I would like to welcome all the audience, and I request them to post their queries in the comment box so that we can have a short QA session at the end of the presentation. And now it's time to introduce our invited speaker for the day, Dr.Yazhini Selluraj ma'am. Madam has completed her MD, DGO, and Diploma in Reproductive Medicine from Germany. And Madam is currently the Managing Director, Madurai Ponni Fertility and Research Center, and Chief Consultant Gynecologist and IVF Specialist in Madurai. So, Madam is practicing fertility treatment for the past 15 years. And Madam was also the former Assistant Professor in Ozit Department, Madurai Medical College, Madurai. And Madam is associated with various societies like IFS, ISAR, MOGS, Indian Menopause Society, PCOS Society, and FOXY. Madam is also the editorial board member of International Journal Annals of Clinical Case Study and Reports, University of Texas, USA. Madam has presented more than 350 presentation in both national and international conferences, and Madam has received various awards to her service, like Amazing Woman Award from and Woman Entrepreneur 2015, and Bharat Ratna Dr. APJ Abdul Kalam Award Excellence Award, and Moyen Awards 2018 at Malaysia. And Madam has also received a Best Clinical Paper Award in Fertivision 2019. Madam has received certification in of Achievement Award in World Congress on Human Placenta, Fetal Nutrition and Metabolism in Las Vegas, USA. With this introduction, I welcome you, ma'am, and I would like to hand over the session to you, ma'am.
Can you show my screens? Thank you so much for your kind words. At the outset, I would like to thank the Shield Pharma and Mr. Ramalingam and Bhargavi and others for giving me this opportunity to deliver my speech on, next slide. Next slide, please. Deliver my speech on poor ovarian reserve. Next, please. Next slide. Okay. Yeah. No. Please go to the, yeah. Thank you so much. And ovarian reserve, we all know, is the functional potential of ovary, and it reflects the number and quality of remaining follicles and oocytes in both ovaries at the given age. And in India, some few decades ago, we had a lot of fertility, and wherever we turn, we could see that there were the red inverted triangle. So advising us to have a small family norm. But nowadays, what happened to our fertility? It is all is attributed to the age of marriage, the lifestyle modifications, the sedentary work we are doing. That is, most of the time we are sitting in front of the systems or computers. The exposure to environmental toxins like plastics and pesticides, all these things had a deleterious effect, and postponing the marriage as well as the childbirth. All these things have had a very bad impact on our fertility. And now let me tell about the developmental origins of ovarian reserve. We have the primordial follicles developing in the intrauterine life between 18 and 20 weeks of life. It starts from the genital ridges. At that time, he used to have 7 million of primordial follicles. But there is continuous atresia occurring in these follicles. And at birth, it is reduced to around 1 out of 1 million. At puberty, it further reduces to 3 lakhs. But throughout a reproductive life, a woman ovulates only 400 or 500 times only. In premenopause, the uh, follicle count will be less than 1,000, and at menopause, it is almost depleted. Next slide. Yeah, ovarian reserve indicates a reduction in the quantity of ovarian follicular pool in women of reproductive age group and is an important cause of infertility in many couples. The existence of fewer ovarian reserve has been unmasked due to an increasing acceptance of in vitro fertilization and as a modality of treatment of infertility. It is believed that approximately 10% of women who undergo IVF show this poor response to gonadotropins. However, the incidence may be much higher in the infertile population, as many of them neither complete the evaluation or go for IVF. Next slide. Now we'll see what is diminished ovarian reserve. It is a phenomenon often noted in women in their mid or late 30s, but it may affect younger women as well. It is believed that there is an accelerated decline in follicular pool at the age of 37 to 38 when it reaches below a critical of 25,000. Subsequently, there remains a very limited time for conception with one owns eggs. It is believed that this phenomenon is accompanied by declining quality due to aging oocytes, and hence young women with POR may have better chance at conception. However, recent evidence challenges this, and the poor ovarian reserve may be associated with low pregnancy rates irrespective of the age, and there will be also high pregnancy loss. Next. Now let's see the causes for the diminished ovarian reserve. It may be idiopathic or some genetic conditions like 45X mosaicism, and sometimes injuries happening to the ovary, either by chemotherapy or radiotherapy or surgery, or gene mutations. And these people have a clear family history of poor ovarian reserve running in their families. Smoking has a very deleterious effect over the reserve, ovarian reserve. And advanced age, of course. When a woman crosses 35 years, the ovarian reserve declines a lot. Then you have this other factors like autoimmune disorders, viral infections, galactosemia, and tubal surgery. Next, please. Next. Age. Fertility peaks before the age of 30. Sorry, previous slide. Yeah. Fertility peaks before the age of 30, and thereafter it is believed to decline gradually. This is due to a reducing primordial follicular pool as a result of ovulation, but predominantly because of follicular atresia. A mathematical model proposes that women experience a biphasic exponential decline in ovarian follicles, a slow decay from birth till 38 years of age, with an accelerated decline thereafter. Recent evidence challenges this view and suggests that the decline is due to progressively increasing rate of atresia throughout the reproductive period. This power model also highlights the difference in the size of non-growing follicular pool between women. Even among those with normal ovarian reserve of same age, the difference in the size of follicular pool can be as high as 100-fold. However, it is unclear at present whether this is due to the difference in the size of the initial follicular pool or due to differences in the rate of depletion. Available data suggests that the non-growing follicles at different ages may have a differing response to changes in hormone levels associated with age. Next. Follicular atresia has important clinical implications for ovarian stimulation, as the magnitude of recruited follicles is proportional to the size of non-growing follicles. In addition, women of all age groups with non-growing follicles below the normal range would have a suboptimal response to ovarian stimulation and experience a shortened reproductive lifespan. Considering a fixed time interval between end of fertility and menopause, these women would undergo an early menopause. Next. And this shows that how a female age has a deleterious effect on the quality as well as the quantity of oocytes, and also it has a negative impact on the live birth rate. Next. And Steve et al. In Estre 2018 said that the probability of blastocysts being euploid declines with age. He did 1,220 trophectoderm biopsies from 436 patients and proved that around 50% of women older than 35 years have a decline in the production of euploid blastocysts. Next. And this graph shows that the negativity of blastocysts being euploid progresses with age. As the woman advances in age, she is unable to produce euploid blastocysts. Next. And what are all the things that affects the ovarian reserve? Prenatally, exposure to pesticides, plastics, androgens, all these things can have a negative effect over the ovarian reserve. Then in the adult exposure, that is, nutrition plays a vital role. Either underweight or overweight has an impact over the ovarian reserve. Cigarette smoking, as we have already discussed, and ethnicity. That is, it is interesting to note that European women age lesser than our Indian counterpart, 5 years. That is, Indian women are 5 years ahead of the reproductive aging when compared with European women. The economic factors and education, cognitive function also has an impact over the ovarian reserve. Next. Endometrioma and its surgical excision is known to cause poor ovarian reserve. Mechanical pressure on the ovarian cortex, it impairs the vascular networks, it alters the cortical stroma, and it has a mechanical effect over the developing follicles, and thus damages the ovarian follicles. Next. Tuberculosis. Tuberculosis is very common in India. Even in its latent form, is increasingly being recognized as a cause of POR in Indian women. Such women are known to have abnormal ovarian reserve tests and show signs of poor response, requiring high doses of gonadotrophins for ovarian stimulation and reduced oocyte yield during IVF. The mechanisms involved in the absence of obvious structural damage is not understood at present. Chlamydial infection is known to adversely influence the ovarian response in those undergoing IVF. In recent years, uterine artery embolization for treatment of fibroids is found to be yet another etiological factor of POR. Next. Genetic mutations. They alter the expression of certain genes in cumulus as well as in the granulosa cells and have implicated in its etiology. The FSH receptor polymerism is considered to be an important cause of unexpected poor response in young women undergoing IVF. Mutations, polymerisms, and alternatively sliced variants in follicular stimulating hormone receptors have varied effects on receptor function. They are believed to bring about structural change in the receptor, thereby reducing the hormone binding ability or the hormone inducing signaling ability. Certain types of mutations, like the fragile MR1 gene, are known to be associated with reduced ovarian function reserve in young women. Next. How to work up? What are the causes how to find out the cause from the history. You should get a detailed menstrual history of the patient, the regularity of the cycles, the staining, the bleeding in between cycles, the changes in the period's length and heaviness, then a basal ultrasound involving the uterine characteristics, ovarian volume, and antral follicle count. Then the blood work like ovarian reserve test, AMH, estradiol, FSH, LH, and progesterone. Then the general wellness assessment and genetic screening, this carrier screening or karyotype. All these things will help us to find out the cause for this for ovarian reserve. Next. The markers of ovarian reserve are the basal day 3 follicular stimulating hormone, antral follicle count, anti-Mullerian hormone, basal estradiol, ovarian volume and its blood flow, basal serum inhibin level, and basal ovarian volume. Next. Ovarian reserve test aims at identifying women at risk of hypo or hyper response to ovarian stimulation, detecting reproductive lifespan, and approximate the menopausal timing. And it also helps to individualize the management to optimize the ovarian response. Ultrasound markers are ovarian volume, antral follicle count, ovarian stromal vascularity. The hormonal markers are anti-Mullerian hormone, FSH, inhibin, and estradiol. Next. And this shows the Doppler study of finding out the echogenicity, the vascularity of the ovaries. Next. And this is how we count the follicles, how the AFC, antral follicle count, is made from the second day of the cycle. And we can use Sono AVC also to find out when the number of follicles is very high. It can give a predictive value of the AFC. Okay. Next. AMH is a glycoprotein, originally known as Mullerian inhibiting substance, appears in females at puberty, produced by granulosa cells of preantral and small antral follicles, measuring about 4 to 6 millimeters. And it is not expressed by the atretic follicles, or theca cells doesn't produce it. Next. And this shows the relationship of AMH with other biochemical predictors of ovarian reserve. See, AMH is FSH independent, and it is under the control, paracrine control, whereas inhibin and estradiol are under the influence of FSH or under the endocrine control. The AMH gene expression and total AMH protein is increased until a follicular diameter of 8 millimeters, after which a sharp decline occurs. In vivo modeling confirmed that 5 to 8 millimeters follicles make the greatest contribution to the serum AMH estimation. Next. Next. Why AMH stands out? Because it is non-dependent of the endocrine. It is independent of endocrine control. And FSH, estradiol, inhibin are all part of the feedback system where they are all interlinked. And moreover, a lot of changes occur as age progresses. Next. How to select the poor responders? We have to do the day 3 FSH, which will be more than 15 to 17 milli-international units per ml. And day 3 estradiol will be less than 60 picograms per ml. Day 3 LH will be more than 45 picograms per ml. And AMH will be measuring from 0.5 to 1.2 nanogram per ml. And the ovarian volume will be less than 3 centimeters. Antral follicle count will be around 5 to 7 when we do the count from both the ovaries. Next. Serum estradiol alone is not very sensitive. When it is combined with FSH, it gives a better idea about the ovarian reserve. When the E2 level is more than 80 picogram on day 3, it will result in higher cycle cancellation rate. Next. Inhibin B It's a heterodimeric protein similar to AMH. The levels of more than 45 micrograms per ml shows the poor response to induction. And it has a high false positive rate, so it is not widely used nowadays. Next. Now we'll move on to the diagnostic criteria. Next slide. Next. Yeah. Estre defines a POR using the Bologna criteria when at least two of the following three characteristics are present. One, the maternal age more than 40, or it is associated with any other factors that can cause the poor ovarian reserve. And previous poor ovarian response when less than 3 oocytes with conventional stimulation of more than 149 international units of FSH daily have been given, gives a history of poor ovarian response. On an abnormal ovarian reserve test, where the AFC is less than 5 to 7, and AMH between 0.5 to 1.1 nanogram per ml. That is 2 episodes of POR after maximal ovarian stimulation is also labeled as poor responder from the previous history. Next. So in Bologna criteria, only the AMH and AFC are taken into account, but live birth rate is not counted. That's the fault of this criteria. So next slide. Next, yeah, we should go for the accountability of the live birth rate also. So what should be our goal? It is to maximize the oocyte yield, increase the chance of having at least one euploid embryo for transfer so that the implantation will go up. Next. Next. Here comes the Poseidon group. That is the patient-oriented strategies encompassing individualized oocyte number. It's a new, more detailed stratification for the low responders. And the low responders are given another term or have been given a new name as low prognosis. So the concept from poor ovarian reserve has moved on to low prognosis concept. And it helps to individualize the treatment for all such patients. Next. So according to Poseidon, there are these people are known as the low prognosis group people, and they are divided into 4 groups. Group 1 and Group 3 are people who are less than 35 years of age, and Group 2 and Group 4 are older people who are more than 35 years of age. In Group 1, the woman is less than 35 with AFC more than 5 and AMH more than 1.2 nanogram per ml. And you have 2 subgroups in that, 1A and 1B. In 1A, less than 4 follicles, and in 1B, 4 to 9 follicles. In Group 2, the woman is more than 35 years of age with AFC more than 5 and AMH more than 1.2 nanogram per ml. And there also they have 2 subgroups, 2A, where the follicle count is less than 4, and 2B, where the follicle count is between 4 and 9. And for ovarian response is Group 3, where the age is less than 35, AFC less than 5, and AMH less than 1.2 nanogram per ml. And the 4th group is the age is more than 35, the AFC is less than 5, and AMH less than 1.2 nanogram. In this group, we expect a poor ovarian reserve. And in Group 2, that is, they are called as the hyper-responders or the suboptimal responders. Group 1, we call them as adequate ovarian reserve people. Next. Now, according to these 4 groups, Group 1, it is young, suboptimal with low oocyte number, and Group 3, young, expected low oocyte number. They are the ones who can cause low embryo aneuploidy risk. They have the low embryo aneuploidy risk. Whereas Group 2 and Group 4 have a high aneuploidy risk because of the aging and reduced cumulative live birth rate. Next. So the prevalence of low prognosis among these people. In group 1, the prevalence is around 5%. In group 2, it is 30%. In group 3, the prevalence is 10%, and group 4, it is 55%. So these four groups, they contribute around 47%, whereas the 53% are the non-posidone group people. Next. Next. Here, the bigger one, the non-posidone patients, who are around 53%. The rest, group 1, group 2, group 3, and group 4 contribute to the 47%. And we have to individualize the treatment for these group people. Next. So for this, we take 3 steps. The first is the posidone-based stratification, that is step 1. And in step 2, we estimate the minimum number of mature oocytes needed to have at least one euploid blastocyst for transfer. And in step 3, it is a patient-oriented treatment strategy to achieve the individualized oocyte number. Next. So this is the posidone patient stratification system, where the ovarian biomarkers, whether they are abnormal or adequate, the age, whether it is more than 35 or less than 35, and the number of oocytes that were retrieved in the previous cycles, all were taken into account, and all these four groups are coined. Next. Here, the pre-implantation genetic testing shows a higher improvement in the implantation rate. Not only in that, it also increases the live birth rate. If you don't do this PGT, everything will be low. Next slide. Then this is Santro et al. And his colleagues have published in Frontiers in Endocrinology. They calculated that how much of oocytes or M2 oocytes are needed to produce at least one euploid blastocyst, and they calculated it using an ART calculator, which is a novel predictive model to estimate the number of mature oocytes that's required for obtaining at least one euploid blastocyst for transfer in these type of people. Next. So it is a clinical predictive model to estimate the number of mature M2 oocytes needed to achieve at least one euploid embryo for transfer in infertile couples undergoing assisted reproductive technology. And that provides a revised estimate of the probability of achieving these outcomes when fewer than the predicted number of mature oocytes are obtained after one or more oocyte retrieval cycle. So it helps to maximize the output with minimum effort. Next. This is a model of the ART calculator where the female age, the sperm source or the sperm count, and how much of mature oocytes are needed to achieve one euploid blastocyst are taken into account. Next. So this shows that the most optimal treatment strategy is planned with a mindset to achieve the posidone marker and take them to success. Either GnRH analog regime or gonadotropin dose, the drug type, the trigger strategy, the adjuvant therapy, whether we can combine it with other strategies, the personalized use of laboratory technology, and the personalized gluteus phase support. So one size won't fit into all, won't be adequate for all. So we have to individualize the treatment for each and every group of people individually. Next. So this is the 53% non-posidone group, or where we don't have a previous stimulation and patient have a normal or high ovarian markers. In managing the high responders, our aim should be to obtain the individualized number of oocytes And we should try all our efforts to avoid OHSS, ovarian hyperstimulation syndrome. For this, we can use a GnRH antagonist protocol, recombinant FSH, only pen, so that we can reduce the dosage. We can start from minimal dosage, and the GnRH trigger, analog trigger, can be used. Instead, we have to avoid HCG. And in normal responders, it also aims at individualizing the number of oocytes with lesser drugs and shorter duration of stimulation time. Either we go for an agonist or an antagonist protocol, and the recombinant FSH alone or a recombinant FSH alone, along with recombinant LH, can be combined. And either we can use a HCG or GnRH analog for trigger. Next. This is another study by Forlow and Sandro. And it says that they coined an index called the Follicle to Oocyte Index. This is understanding the ovarian hyperresponse to exogenous gonadotrophin. If you see how much of follicles have, from which we have obtained the oocytes. If we have, say, 20 follicles, and we obtain only 5 follicles, then the FOI, that is the follicle to oocyte index, is very low. Next slide. So there is a normal FOI, that is when the oocytes retrieved is more than 50%. Suppose we have 20 follicles and we have retrieved 12 follicles, then the FOI is more than 50. If we have 10 and we have obtained 6, more than 6, then the FOI is normal, more than 50. And the low of FOI, that is follicle oocyte index, is when you have 20 and you have retrieved only 5 or 6, then the FOI is low, less than 50. If you have 4 and have obtained only 1, then again the FOI is low, less than 50. So what are the pathogenesis for the low FOI? It may be the starting dose of gonadotrophin may be very low, not sufficient, or there may be some genetic or environmental factors that affects this, or it may be asynchronous follicular development and technical issues involving the triggering. The final trigger may not be sufficient for to make the to obtain a mature oocyte, or the pickup may be difficult. There may be some difficulties, technical difficulties in ovum pickup. Next slide. Yeah, here we go for individualization of treatment. For group 1, when the people are young, less than 35 years, they have a good reserve with good quality of oocytes. The possible reasons where the response may be poor may be due to the low gonadotrophin starting dose, or asynchronous development of the follicles, genetic polymorphisms of FSH receptor and LH receptor, and the trigger and ovum pickup issues. And for them, the controlled ovarian stimulation, we can use a GnRH antagonist protocol, priming with OCP, norethistone E2, and recombinant FSH is the preferred gonadotrophin over the urinary FSH or HMG, and we can increase the recombinant FSH dose, or we can even add recombinant LH supplementation. For trigger, either HCG or GnRH analog can be used. The transfer may be either fresh, or we can go for a FET with PGTA, that is a pre-genetic implantation testing. So the measure of success is the number of oocytes needed to obtain at least 1 euploid blastocyst for transfer. The overall minimum of 5 mature oocytes is needed in this group to obtain 1 euploid blastocyst. And in group 2, they have a good reserve with poor quality because their age is more than 35. The possible reasons are almost the same as that of group 1. And the stimulation it's better to go for a gene-origin antagonist protocol and recombinant FSH to be used. You can combine it with LH supplementation, and we can increase the doses of gonadotropin also. A double stimulation is a best thing for this type of people. And trigger and transfer strategies are almost same as that of the group 1 people. And here, the overall minimum of 10 to 12 mature oocytes are needed to obtain 1 euploid blastocyst. Next slide. Next slide. Here, this study shows that it's a systematic review analysis where the recombinant LH is supplemented to obtain the maximum output of good oocytes. And who are all chosen for this are the hypo response, those who are having hypo response to the recombinant human FSH monotherapy. So we have to combine with recombinant LH. Those who are in advanced stage, nearing 40 or above 40, and co-treatment with GnRH antagonist, profoundly suppressed LH levels after the administration of GnRH agonist, or those who have encountered normal responders with high risk of OHSS, and poor responders to ovarian stimulation, including those who met the Bologna criteria. So the main outcome measures are the implantation rate, the number of oocytes retrieved, the live birth rate, ongoing pregnancy rate, fertilization rate, and the number of M2 oocytes that were obtained. Next. So this shows that from 4 studies involving 672 women, where recombinant FSH was combined with that of recombinant LH, they yielded a better number of oocytes, and the implantation rate was also very good. Next. Here again, the combination of LH with that of recombinant FSH has given a very good result, and this is a study conducted by Sandro. Next. Here, the patients with low FOI, that is those who have a follicle oocyte index lesser than 50. For such people who are less than 35 years, and for those who are more than 35 years, we can go for the FSH, recombinant FSH, and LH supplementation can be done for such people. Next. And managing the group 3 young people where there is poor reserve, but the quality of oocytes is good because their age is less than 35. The reasons for such a poor response may be poor ovarian reserve or asynchronous development of the follicles due to genetic polymerisms also. And the stimulation protocols that are used are long GnRH analog protocol or GnRH antagonist can be done. A double stimulation or dual stimulation can be done. And stimulation should not exceed 300 international units of recombinant FSH. It can be combined with the pre-treatment with androgens or growth hormones can be also added. The embryo transfer strategy may be either fresh or FET can be done. And oocyte or embryo accumulation can be also tried in these people. And the average number of 4 to 5 oocytes are needed to obtain 1 euploid embryo. That's the measure of success. And in group 4, group 4, where the age is more than 35, they have a poor reserve with poor quality oocytes because their age is more than 35. And the reasons are almost the same because the high aneuploidy rate is here in these patients. And you can go for a long GnRH protocol, GnRH antagonist protocol, a double stimulation, or the stimulation should not exceed 300 international units of or a recombinant FSH plus recombinant LH. The androgens and growth hormone can be added. Fresh transfer or a FET can be done, or oocyte or embryo accumulation can be also tried. And in average, a total of 12 oocytes are needed to obtain 1 euploid embryo. That's a measure of success. Next. This is a double stimulation where you have stimulation in the same cycle, in the follicular phase as well as in the luteal phase. In the follicular phase, we start our stimulation with recombinant FSH, or it can be combined with recombinant LH also from day 2 for 10 days. And you can add antagonist from when the follicle reaches 14 millimeters. And on 10th day, you give the trigger, GnRH analog trigger is to be given, and plan the ovum pickup 35 hours later. Then after ovum pickup, we have to stop everything for 4 or 5 days. Then we can start from day 18, the stimulation with recombinant FSH or the recombinant FSH and LH combination. This is the luteal phase stimulation. And GnRH antagonist can be combined when the follicle reaches, goes beyond 14 mm. Then on day 28, you give the GnRH analog trigger and do the pickup 35 hours later. So this helps to yield a more amount of oocytes and also prevents the dropouts. This is a dual stimulation is very good for group 3 and group 4 people. Next. This is a SWOT analysis which deals with the strengths, weakness, opportunities and threats of using this double stimulation. It's a high number of oocytes, the embryo obtained per ovarian cycle, and more patients obtaining blastocyst, chromosomally normal per ovarian cycle, and no difference in competence between the oocytes obtained in follicular phase stimulation as well as luteal phase stimulation. The weakness are the higher number of stimulations in the luteal phase, and there is no RCT or it is a cost effectiveness. We have to definitely undergo a freeze-all approach that is mandatory and is applied only to poor prognosis patients with reduced ovarian reserve. And the opportunities, it might reduce time to obtain at least one competent embryo in a single menstrual cycle. It might be better tolerated from patients than consecutive follicular phase stimulation cycles. Theoretically, it reduces the dropout rate and it may increase the knowledge regarding the mechanism of follicular recruitment and ovarian physiology. The threats are cost effectiveness and increased total number of gonadotropin administration than conventional COS, and few biological, gynecological, obstetrical, and neonatal evidence of safety produced to date. Next slide. These are many studies which show that 300 internationals of gonadotropin is more than sufficient. We need not go beyond that. Next. So the novel Posidion classification of low prognosis patients in ART combined with use of patient-oriented strategies to achieve the individualized oocyte number as predicted by the ART calculator should be considered by clinicians to reduce the time to live birth. This new system may help improve patient counseling and management with an expected positive effect on IVF success and time to live birth. Next. Leucine metabolism and mTOR signaling. Leucine is an essential amino acid which acts as a substrate for protein synthesis, acts as a metabolic fuel, and as a nitrogen donor for synthesis of glutamine and alanine. It prevents the protein degradation. It is obtained from diet and not synthesized in our body. The mTOR, a part of two distinct multi-protein complexes, mTOR C1 and C2, positively regulates the cell growth and proliferation. This helps in the activation of dormant primordial follicles and helps to trigger its growth. Next. So the impact of leucine on AMH and AFC is it increases both, and there is increase in the oocyte quantity as well as quality. It yields the M2 receptors more, and grade of embryos also improve with pre-treatment with leucine and mTOR. Next. So this is a study which says that the AFC improves from 6.9 to 8.2 after treatment for 90 days, and the oocyte number also increased from 4.53 to 5.53. The metaphase 2 oocytes also were going up in number, and the average number of day 3 cleavage had a grade A embryos. Before treatment, it was 1.4, and after treatment, it was 2.23. Next. Next. That is the graphical representation of what I said. Next. So to summarize, this is a plethora of therapeutic interventions in the management of POR. We have all the things that were said earlier. Next. So what are the future? How you hold the future in the management of poor responders? You have the rejuvenation medicine, that is the platelet-rich plasma, the stem cells, and the mitochondrial replacement therapy. Next. Platelet-rich plasma is rich in growth factors and cytokines and has been used as an agent that induces tissue regeneration. PRP also promotes follicle development in vitro and has been utilized in small case series as a potential treatment for women with poor ovarian reserve. A few case studies have shown that intra-ovarian injection of PRP in women with poor ovarian reserve resulted in an increased number of M2 oocytes and cleavage stage embryos. However, little is known about the effect of autologous ovarian PRP treatment on oocyte and embryo quality. A number of cytokines and so many growth factors are present in this platelet-rich plasma, which help to produce or increase the ovarian reserve. Next. This is the way how we prepare the PRP. And next. We in our hospital, we do the ultrasound ultrasound guided intra-ovarian autologous PRP injection using the 17 gauge ohm pickup needle. 1 to 2 ml into each ovary is instilled, and it's a OP procedure. Next. And this is our statistics. And I have done intra-ovarian PRP in 6 patients. And these are the values, the LH, AMH, FSH, E2, before PRP and after PRP. See, there is a marked improvement in that. And 4 out of 5 have delivered, and 1 had a abortion at 3rd month. So it gives a success of 66.66% live birth rate. Next. This is use of autologous stem cell ovarian transplantation to increase the reproductive potential in patients who are poor responders. Next. This is how to overcome the mitochondrial dysfunction. Either we can improve the mitochondria or we can replace the mitochondria. Next. To improve the mitochondria, you can use a CoQ10, which decreases the ovarian atresia, restores the oocyte mitochondrial gene expression, and improve the mitochondrial activity. Next. This is a third-party ooplasm transfer, where the mitochondria is replaced. Next. This is the type of mitochondrial transfers. There is donor ooplasm and self-somatic cytoplasm or self-ovarian mitochondria. Next. So the best judge is the couple themselves. We should mind their mental and physical health. It's very important. Can they afford to continue? That's a big question. Will they be happy only if they have a biological child? Or do they simply want to be a parent, no matter whose child it is? So these all things will attribute or will help us to design the treatment protocol for these patients. Next. So the take-home message is, in POR, no need to advise donor oocytes. A dedicated and continued counseling is mandatory, giving realistic expectations. Double stimulation, oocyte accumulation, or oocyte pooling increases the oocyte number and decreases the dropout rates. Mild COS and conventional stimulation protocols with 300 IU gonadotrophins may be sufficient. And DHEA and testosterone growth hormone have limited evidence. LH supplementation can be tried since there is unlikely to be a determined effect. Ovarian rejuvenation is a highly promising method, and it is a boon to the couple who earnestly desire their own genetic component offspring and brings hope to women suffering from poor ovarian response. Next. See, one size does not fit all. So individualization of stimulation protocols trigger the embryo transfer and the luteal phase support. Next. Will increase the live birth rate. Next. Next. So I would like to conclude my speech stating that nothing is impossible, because in impossible, there is I am possible. Thank you so much for your patient listening. Thank you so much.
Thank you, ma'am. Thank you very much.
Yeah, you can ask questions.
Yes, ma'am. As you rightly said, one fit does not fit all, ma'am. And once the management and the treatment of patients with a poor ovarian response is still controversial issue in IVF, ma'am. So thank you very much for the detailed and elaborate talk, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I will for you.
Yeah.
Ma'am, you are talking about the importance of leucine in this poor ovarian response, ma'am. So, what should be the ideal dose, and how long you will recommend to get the optimal effect, ma'am?
I think 90 days. It has to be given for 90 days, 3 months, and I'm not very sure about the dose, because I used it some 2 years ago, but not now. So I don't remember, but it gave very good results.
Okay.
Leucine, of course, leucine I'm using now. Yeah, I think that's one BDF. I'm not very sure. I'm using leucine now. Yeah.
So fine, ma'am. Ma'am, and what will be the effect of this leucine in preventing aneuploidy, ma'am?
Yeah, it is. I already told you, no, because it's a big pathway, which is very tough to explain, and it was in the chart also. Can any one of your colleagues help me in this, because it's a long thing that helps to produce a good quality M2 embryos. I mean, oocytes and then the embryos.
Okay, ma'am.
Can anybody, because it's a long pathway, highly complicated.
Congratulations, Yalini. I am Dr. Saroja Velusamy.
Thank you, Ka.
Congratulations, Yalini.
Thank you, Ka. Thank you so much.
Where do you get the PRP? I am not using this much of methods, but I want to know how you are getting the PRP.
Yeah, it was PRP was taught to me by Dr. Suryakant, one doctor from Delhi, and we conducted CME also in Madurai.
How do you get
PRP.
From where you are getting?
Yeah, I got it first from him. Now in Madurai itself, it is available from Shreyas.
Oh.
From Shreya.
There is no an allergic reaction or anaphylaxis?
Nothing is there, because this is autologous. It is your own plasma. It is derived from your own plasma. So nothing is, no anaphylaxis or no, we are not getting a donor one. This is our own plasma.
LH, recombinant LS, trade name?
You were in?
You have mentioned about recombinant LH also.
Yeah.
Trade name of the recombinant LH.
Luverin. Lueverin. Am I right?
Luverin.
Yeah.
Okay. How much we have to give? How much you are giving?
Either we can use
70
units. Yeah, 75 or 150, depending upon the
70?
response. 75 international units or 150 international units, depending upon the
as usual, there is FSH and This one. Okay, okay. Thank you very much. Nice deliberation. My congratulations to you.
Thank you,
Such
sir.
a enormous and elaborate lecture. Exhaustive lecture. I don't know how you presented. Okay, thank you very much. Okay.
Yeah, when I read about this, it was so complicated, but I have simplified it.
The summary was very good. Summary was very good.
So that it will be useful for others. I simplified it.
Okay, Alini. Okay, thank you, thank you, thank you.
Okay, okay, guys. Thank you for your comments.
Okay.
Thank you, ma'am. And ma'am, we have another one question, ma'am. Like, what will be the role of vitamin D3, ma'am, in producing good Ozit, ma'am?
Yeah. I am using vitamin D3, and for all this pre-treatment, we give the 60K weekly once for 8 weeks, and then after we start the stimulation, we switch over to the syrup form, 0.5 ml daily, and they will be continuing till delivery. Vitamin D3 0.5 ml, which delivers 400 international units of vitamin D.
The vitamin D3 is a Sagalagala Nivarani.
We don't know. We want to produce
prevention of hypertension, prevention of GDM, for everything we can use.
Yeah,
this
though
one.
we are living in a tropical region, we are still suffering from vitamin D3 deficiency. That's the problem. We are not exposed to
nice
sunlight.
Deliberation.
Thank you, Ka.
Another one question is: are you investigating with Inhibin regularly, ma'am?
No, I am not doing it. That's why I mentioned it is outmoded. And clomiphene challenge test is also one that has been not done nowadays.
Fine, ma'am.
Anything else?
I do not find any other questions in the chat box, ma'am.
Okay.
If there is any questions, then we will be forwarding to your mail ID, ma'am. You can address on those questions, ma'am.
Okay, thank you so much.
Thank you very much for
Thank
being
you.
with us
Yeah.
today. You have spent your valuable time with us today, ma'am, and stay safe and healthy, ma'am. And I'll also thank the participants for their active participation and listening. And I also like to thank our team, that is Nutri Synapse Division, for making this webinar possible, ma'am. Thank you, ma'am.
Yeah, I once again thank the Shield Pharma for giving me this opportunity. Thank you so much. Thanks a lot.
Very much. Thanks, madam. Thanks a lot.
Thank you, sir. Thank you,
Balaji
sir.
here from Shield. Thank you.
Thank you, sir.
Thank you, madam. Thank you.
Thank you, ma'am.
Thank you.